Good afternoon, and welcome to today's live discussion on COVID-19 and cross-cultural care. I'm your host and moderator, Michele Courton-Brown, CEO of Quality Interactions. Today's discussion features my friend and colleague, Dr. Joseph Betancourt, First Vice President and Chief Equity and Inclusion Officer at Mass General Hospital. He is also the founder and director of the Disparity Solution Center at Mass General Hospital, an associate professor of medicine at Harvard Medical School, and a practicing internal medicine physician. Dr. Betancourt has a well-deserved recognition around the world, really, as an expert in healthcare disparities and cross-cultural medicine. And he's also the co-founder of Quality Interactions. I do have a programming note before we begin the session with Dr. Betancourt, and that is that earlier today we taped a session and discovered that the sound quality wasn't quite where we wanted it to be. So we're re-recording for purposes of dissemination today. So we're asking the exact same questions, but doing it again for purposes of improving sound quality. So with that, I want to welcome my friend, Dr. Joseph Betancourt. How are you?
I'm great. Thank you, Michele. I appreciate the time, and thanks everybody for listening in. You know, it's with a lot of humility that we hope to share some lessons learned here, given what we've just been through. So I look forward to this conversation.
Indeed. So Joe, I want to kick it off because you play a key leadership role in the COVID-19 response at Mass General Hospital. I'd like to know if you might share with us what you've been up to and also what you've seen.
Great, thanks. So yeah, these last couple of months have been very challenging in a lot of different ways and required a lot of all of us. And I think, you know, for me, I had a really incredible opportunity to think about equity and community health as it related to COVID pretty early on. I was asked by our healthcare system, Mass General Brigham, formerly Partners Healthcare System, to stand up an effort in response to COVID-19 around equity and community health. And we did that pretty early. We started that, in fact, March 16th. And so we've had quite an experience. And I think for me, this was an opportunity to think in a very substantial way about ways in which equity and community health and today's discussion, cross-cultural care and communication, might play a role as we addressed COVID. And now I'll be able to share reflections about the role that it did play. I'll maybe take a moment to talk about kind of that process. You know, it was early March when we began to get dispatches from Italy in particular about how they were being overwhelmed, and our healthcare system, Mass General Brigham, really, as well as Mass General Hospital, I led that effort along with partners in community health, really tried to say, what are the things we need to think about, given that we expect people will be coming to us with COVID-19 infection, and how do we make sure that we're meeting the needs of diverse populations? And so on the Mass General Brigham, I'll say MGB, on the MGB side, we created a series of work streams. You know, our first work stream was, how do we identify individuals, doctors, nurses, frontline staff, researchers from across the enterprise who speak a language other than English, with the idea that we may want to, as we redeploy people in different positions to meet different needs, use language as an asset. Another key area was that we were going to be engaging in clinical communications with patients and with our employees through occupational health. How do we make sure that everything we did in those interactions was done in a way that people could understand and in their language? So there was a clinical communication to patients and employees work stream. There was also a general communication to patients and employees work stream, which is the idea that we were communicating with a lot of our patients through our patient gateway, our electronic health record. We knew that a lot of minority and vulnerable populations weren't on gateway. So how are we going to ensure that we were getting information to them? Same with our employees. We got almost daily updates as information changed day to day on COVID-19, and we got those through email. Yet we know that there were large groups of our employees who couldn't get that information via email. So we developed a whole series of strategies, an emergency text messaging platform to democratize information for both patients and employees. And then we engaged in a whole series of community-based efforts, particularly focused initially on social determinants and social needs, but then pivoting very quickly as we began to see that communities of color became our hotspots and became our nation's hotspots. And I'll end by saying, Michele, that the reason we stood this effort up is because history tells us over and over again that natural disasters like this, and certainly this isn't a pandemic of unprecedented nature, but we anticipate always that these will disproportionately impact negatively minority populations. If we think about Hurricane Katrina and how it disproportionately impacted poor Black people. Why? Because they lived in lower lying areas, less investments in levees, lower socioeconomic status. So those are all issues that I think really undergirded why we stood this up. And I think this was a really important effort, and we've learned a lot.
Indeed. So you and I have had many conversations over the years about the role of health disparities and how they've played out in significant relief. You've begun to share that in this experience. We could have predicted this, right?
Yeah, we could have, and I think even me, I think we were thinking a lot about the incoming, but we learned a lot about the kind of upstream prevention here. And so let me maybe talk a bit about some key factors here as we think about this. Well, we understand, and the science tells us that COVID disproportionately had a disproportionately negative impact from a health outcome standpoint on those who are older and those who had previous health conditions such as diabetes, heart disease, cancer. We've learned that more and more. COVID is not just a respiratory disease. It's a disease that affects multiple organ systems. But ultimately, I'd say we start with a history of structural racism and other factors that have set up our communities to enter this pandemic with significant disadvantages and an unequal burden of disease that already puts them at a disadvantage. Then we add to that we have a virus that is easily spread, respiratory, and is spread while people are asymptomatic for up to 14 days. And so you can begin to imagine a series of conditions whereby the spread of COVID-19 could be very, very active. And that's exactly what we saw in communities like Detroit, New Orleans, Chicago, Queens, New York, as well as New York City, and Chelsea and Revere, Massachusetts. What do we know about these places? What we know is that these are places that are densely populated. So it's a numbers game. The more people you have, the more likely there is to be spread. They tend to have lower socioeconomic status. What does that mean? That means that you have smaller housing, and maybe you're taking care of several extended family members. That also means that you're likely to be an essential worker and work at a market, work at a hospital, work in some form of transportation, where you do not have the luxury to socially isolate. You have to get on the train and the bus to get to work. This is way before we were telling people to wear masks. You're not getting groceries delivered. You're not working remotely. And so when you think about this, you know that these sets of social conditions, adding to that these are all often communities that have lower health literacy, lower access to care, language barriers, immigration issues, and significant mistrust that we have in communities of color. That's another layer that further creates a perfect storm for why we saw COVID-19 disproportionately impacting communities of color across the country. It is not that people of color are genetically more susceptible. This has nothing to do with it. This is strictly a science based on a very difficult history in our nation of how our communities of color live and have lived and have been treated over history's time. And so I think it's for all those reasons that we understand that this pandemic hit communities of color early, and it hit them hard, and they became our hotspots not only locally but nationally.
So you've been in the eye of the storm, so to speak. Wonder if you might talk about the role of cross-cultural communication and cross-cultural care, and how that came to bear in the work that you were doing.
Yeah, it's a great point. I want to talk about some additional factors I think that led this pandemic to impact communities of color, and I want to let everybody know that in my experience, it wasn't just an administrative experience. We stood up something we call our Spanish language care group when we began to see at Mass General Hospital that between 35 and 40% of our patients who were admitted with COVID were Spanish speaking. we knew that our interpreter service was not going to be able to manage that demand. And so we rallied and organized an effort where we identified Spanish-speaking, native Spanish-speaking physicians across, I think, 15 specialties, representing 15 countries, who really stood up and said, we will work side by side with our teams who are caring for COVID patients to bring clinical, cultural, and linguistic competence to that care. I was one of them. So I've done multiple shifts in our testing sites, multiple shifts inpatient, in our ICUs. And so I've been both at the administrative side thinking about these issues, but also at the bedside. And I think there's a couple of different things that we understand. One, from a big picture side, information has evolved every day. And I mentioned already the issue of masks. And, initially, one of the first things I did just in the hospital was go down and speak to some of our employees before we launched the text messaging program about COVID-19 and how they should protect themselves and the like. And, this was early on, and they would say, wait a minute, this spreads by cough or sneeze in close distances, but I'm getting on the bus, I'm getting on the train. And the going thinking that time, and what we were told to tell people was to not wear masks. And now everybody's wearing masks. And so, basically what you've had is communities of color have been the canary in the coal mine that then allowed for information. So now that we all wear masks, and that's created mistrust. I think another key issue related to kind of these sets of cross-cultural care and communication factors is that there's been a lack of trusted messengers and a message tailored for communities of color. You don't create a message and then just translate it. And you have to have a message from someone who people can identify with, can trust, and who they could understand. And in the absence of that, we see misinformation. And there was a lot of misinformation that filled that void. So I think clearly bringing cultural competence and cross-cultural kind of foundational principles to communication there is another key thing, I think, that has been a challenge. I think another one, quite frankly, is that we understand that disparities, as I mentioned, are the foundation in which communities of color enter this. And one thing we've talked about a lot for a lot of years is stereotyping, unconscious bias, implicit bias. And at the end of the day, testing, which was a scarce resource, was still discretionary, and there was an allowance for clinical discretion. And I think many of you have heard of the young African-American woman from Massachusetts in New York who was seen about 3 or 4 times in a healthcare setting, told she didn't need a test, didn't need a test, despite having symptoms. And so you have to be concerned about the way unconscious bias and implicit bias played a role in her not getting a test. And so I think all those factors made this particularly more challenging. Maybe I'll just pivot for a second, Michele, and talk about the bedside and some experiences that I had. So, we've taught a lot about cross-cultural care and communication, the patient-centered approach, or a rescue model, which is, respect diversity, communicate clearly, understand the individual, engage individual, understand difference, engage individual. And ultimately, those principles were essential to everything I stood up, both from the standpoint of a system, but also in my day-to-day interactions with patients. Why? Because mistrust is real, and our inability to build trust at the community level, and our inability to build trust with that person in front of us who's worried about, a new experimental trial they're being offered. Is this the last face I'm going to see because there's no visitors? Are they going to do right by me? Mistrust was a major factor, and we teach about this and how important this is. I think another one is, the role of biomedicine. So here, we tell people we're learning. We have some things we're gonna try, but ultimately we saw the misinformation about a lot of unproven strategies. The 10-second test, hold your breath for 10 seconds, and that's going to tell you if you're sick or not. Misinformation filled that void, and so ultimately, the role we've talked a lot about in our teachings around the role of medicine, biomedicine, and who, the types of things that people follow. And clearly, I think that was something that was unearthed here. Another key one, and this is with the patient who I take care of, we've always talked about the importance of understanding how traditions, customs, spirituality impacts your interaction with me as a caregiver. I had a patient who very early on was admitted with COVID-19, a young man who was a Jehovah's Witness, and he couldn't accept blood products. If we wouldn't have identified that early, we would have been in a lot of problems down the road. So identifying traditions, customs, spirituality was very, very important. I think another big thing that we talk about a lot is the explanatory model, getting people's understanding of why something ails them, understanding of treatments. That absolutely was on view here, where people had a lot of different perspectives around, COVID-19 and how it might impact them. A lot of different perspectives about the treatments they were given. So I highlight this because, COVID-19 has shed a light on, the underinvestments in public health, the social determinants, but it has absolutely shed a light on the importance of the principles of respect, the principles of dignity, of cross-cultural care, communication, in ways that are palpable and that lead to health outcomes, to value, all the things we've been talking about for years. Ultimately, this virus doesn't discriminate, and our inability to care for everyone at a high level ultimately puts everyone at risk, globally, nationally, locally, in our communities. And so I know we've heard for a lot of years, what's the business case? If a complete crash of the economy due to our inability to effectively manage this pandemic, in large part, in my view, because we haven't responded with all the tools that really are at our disposal related to managing these conditions across cultures, there's no better business case than there is now. And I think clearly people really understand in very different ways than they did before the pandemic the importance of addressing disparities and the importance of cross-cultural care and communication in everything we do.
Well, it's been said, let no good crisis go to waste. And I think you've done an amazing job at synopsizing many of the things that you've learned from this crisis. Some of them institutional nature, some of them structural in terms of society and what we need to do there. One of the things that I know that you stood up is greater patient engagement, doing some video work and sending out messages. You want to share a little bit more about that?
Yeah, absolutely. I mean, I think, in the absence of those trusted messengers, I think we tried to partner with multicultural media and have them highlight, these messages. And multicultural media partners were incredibly important. That being said, we realized, let's just take the bull by the horns. Let's create our own videos. Let's use basic technology. Let's think about Facebook Live, WhatsApp. I mean, so I do videos now Monday, Wednesdays, and Fridays in Spanish, about 3 to 5 minute videos on current issues related to COVID. I mean, I think this is important that we fill that void, and we talk about these issues, right? Of kind of things like styles of communication that we've taught about a lot over the years, where people say yes, 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 and they really don't understand. And so our ability to really deliver those messages in ways that they can understand, and then double check that they understand, is critical. We're really in a much better way teaching and training and thinking about building trust at the community level, at the bedside. We're really in much better ways thinking about the importance of assessing, traditions, customs, spirituality, about issues related to a person's understanding of their condition, because that becomes the premise by which you engage people and develop an intervention. So this has been, I think, an incredible experience. It's been difficult. It's been hard, but it's been one that I think is energizing in so much as we feel like we have a whole new set of leaders who tacitly would say, I believe diversity matters. I believe addressing disparities matters. I believe cross-cultural education matters, who now say, hey, you know what? It really matters. And if we really care about this, we're going to invest in making sure that our public health system and our healthcare system has the tools and skills they need to truly provide high quality care to diverse populations. And I think that's where cross-cultural care and communication really comes in.
Yeah, thank you, Joe. That was incredible. I wonder if you, we've got a number of questions from the audience, and I wanted to maybe drill down on a few of them. One is, how can we as interpreters work to educate the community regarding community health issues?
Yeah, I mean, I think, I've always been an advocate for interpreters. I think interpreters play a very, very important role, and I think there's so much more they can do. And I think the nice thing about nice thing. The interesting thing about this crisis is that everybody, it's given us permission to do more outside, excelling above, what our role group has limited us to. And I think, engaging interpreters and their ability to communicate with communities is absolutely essential. So I think, my sense is that everybody needs to, put in their little piece if they can. And certainly if you're an interpreter and you have an ability to communicate to community, find some partners and figure out a way to do that. I think we tried here to empower people to do everything they can. We try to coordinate it, but really to do everything we can to save lives ultimately. This was about saving lives. This virus didn't sleep. Every minute mattered. And, to your earlier point, I mean, I viewed this crisis as an opportunity to do things in 3 months that, quite frankly, would have taken me 2 years to get done. And I think the other beauty of this is that we have in front of us now, as people who care about equity, about disparities, and about cross-cultural care, the single biggest and best evidence-based case study for why this work is important. And not why it's just important for those communities over there, because this pandemic taught us that there are no just communities over there, because we've had a hotspot here in Chelsea. Those were essential workers who were, working at our high-end restaurants and, in those environments. This virus didn't care if who you were. And the message here is that unless we take care of ourselves as a collective, we put everyone at risk. And the skills that we've always been talking about for 20 years, I think were critically needed. When deployed, were incredibly effective. And looking forward, I think we have a whole new set of people who understand this in a fundamentally different way. And if there's any silver lining whatsoever, that's the silver lining that we hope to really gravitate to, that we hope to take advantage of. And I encourage everybody who's listening in to grab on to each other as community, but also to really take advantage of what's just happened, because we do our communities a disservice if we don't stand up for what happened, what was needed, what we did that worked, and how we can be better in the future. And I would argue this work is an essential piece of that.
Absolutely. The business case has been made, indeed. Another question from the participant group. How do we help others to recognize their unconscious biases? How do we do that on the school?
That's, I think, again, people are more attuned to this. Let me give you some examples. I think, at the clinical bedside, I work, side by side with some of my peers, very, very well-intentioned people, who all of a sudden saw the extra value of me bringing, cultural and linguistic and clinical competence to the mix. And it's fascinating because people would be like, oh, I assume that patient X, or I assume that patient Y, they felt comfortable sharing because we were partners in arms, kind of managing these challenges. But I think part of it is, people through this process have been able to discover some of their own assumptions about people, about clinical interactions. And I think that's another thing that we can certainly, take advantage of. But Michele, I think, I'll give you one very concrete example that around unconscious bias that's very real. Part of this process that we engaged in was the dusting off and getting ready to deploy something called crisis standards of care. And basically the crisis standards of care are a document that states and health systems have created to say, if we were to run short on ventilators, what are the set of criteria that we are going to use to allow the usage of 10 ventilators when you have 20 people who need them. And as you can imagine, when that document was really gone through with the fine-tooth comb, it was so susceptible across it to unconscious bias, implicit bias, assumptions. And we did so much work at the state level and certainly in our healthcare system to clean that up. But one of the things we're doing is, if we are ever to need to use them, anybody who's on the triage team is going to be required to go through unconscious bias training, because we understand that in the place of anything that's discretionary, implicit and unconscious biases creep in. And so, that curriculum is going to be incredibly important. curricula around mistrust is going to be very important. Around communicating across cultures is going to be very important. So all these things I think are going to be critically important, just in general going forward, but certainly around unconscious bias.
Right. You know, Joe, you and I talk a lot about the power of one, right? What we as individuals can do. And I'm wondering if you might share how you think we can rebuild trust in minority communities and immigrant communities where societally we may have earned that mistrust.
Yeah. Look, there's zero doubt that trust and mistrust is well-earned mistrust. You look at our nation's history of racism, segregation, medical experimentation, that mistrust is real. So let me reflect on kind of a principle that I think about. One of the things we teach is asking patients when we see them, have you ever had a bad healthcare experience I should know about, right? And then oftentimes hearing what their experience is, and then your process of reconciliation in that individual moment, right? So to me, it's a couple of step process. It's a few steps in this process. Number one, you need to have the courage to ask, a question that gets at how powerful is mistrust for you? Because I know it's for all people of all backgrounds, but and the question we ask is, have you had a bad healthcare experience I should know about? In communities, I could tell you already, the mask examples, we already engendered mistrust already by telling people not to wear a mask, and now people wearing masks. I'm like, what happened when we were telling you we were on trains that were packed? Like, why didn't we get a mask, right? So one is putting mistrust on the table. The second is saying, you know what? I can't explain why that happened, and I'm sorry that information changed. And that apology is really important. Say, I'm sorry. And another key part of it is, this is how we are going to engage going forward, and I just ask that you give me a chance. So at the bedside, we use that strategy, right? But in communities, we need to use that strategy, which is a strategy of acknowledging that there is a well-deserved history of mistrust, apologizing, whether we feel we engendered it or not. Our ability to engage with community is predicated on their sense that we apologize for what has happened, and then to try to say how we will go forward, and to give them an opportunity to feedback and let us know if any time if we're falling short. The research tells us that gives us at least a fighting shot to build trust. It's not easy. Mistrust wasn't built overnight. Trust isn't going to be built overnight, but that is a process that I think we've taught at the bedside and certainly applies to our building trust in the community.
It's so powerful. Sometimes people just need to be acknowledged. They need their feelings and their experiences acknowledged before they can move forward.
That's right.
You have had more than 2 decades of experience in cross-cultural communication and cross-cultural medicine. I wondered if there are any final lessons that you want to share about this pandemic, what we've learned, and what we can make good use of in the future.
Yeah, I mean, I think, to reiterate a couple of points I made, we predicted this would hit communities of color hard, it did. We understand the perfect storm that led to this spread in communities of color. We know where our healthcare system's inability to understand these issues of trust, of effective public health communication at the bedside, communication around new clinical trials, communication around, use of different remedies, understanding. We understand now that portfolio of things that we've been talking about was and is incredibly critical. And I think that's been a major lesson learned. And I think, I guess another major observation for me is that I believe I have a whole new set of allies in ways that are by leaps and bounds different than they were a couple of months ago. There's a lot of people who say they care about this. I think there's people who understand this in a whole different way. So my view fundamentally is we as a community who cares deeply about this, we need to activate ourselves and really bring this evidence forward and say, do we want this again?
Right.
This is what failed us. What are we going to do to be better? And I would strongly argue that a lot of what we've been talking about for 20 years is really, really central to a public health and community-based response and to a healthcare system and bedside response. I don't have to argue it. I have the evidence to show it. And so I think not just me, I think we all do. And it's incumbent upon us as leaders in this space to really step up and say, this is what's needed. And it is not a nice to do. It is an absolutely necessary to do. And it's not just for COVID-19. It's for diabetes, it's for hypertension, it's for asthma, it's for heart failure, it's for cancer screening. It's for all those things that disproportionately impact communities of color and are all low value. They cost our healthcare system a lot. It leads to poor health outcomes. It's a lot of variability. And it's all the things that we say as a healthcare system we're trying to address. If we don't address them in these ways with cross-cultural care at the foundation, we're going to continue to fall short.
Well, Joe, I think this is an incredibly powerful way to end our conversation. I want to thank you for your time and for your wisdom, and for bringing that frontline experience and perspective to our audience. We know that cross-cultural communication and care is essential to caring for our increasingly diverse patient population. And I just applaud you for the work that you're doing on behalf of Mass General Hospital and around the country. So thank you, Joe.
Great, thank you all so much, and thanks. It's been a pleasure to be here with you today and to humbly share again, what I've learned. I think this has been a difficult time, but I think this is a time where we can really be better on the other side. And I think it's really it's what we do with this situation, this opportunity that's going to define us in the long term. So I appreciate everybody who cares enough to listen in, who does this work, and we'll always be here as a partner for you. So thank you.
Thanks. Have a good day.